okay? You guys are going to hate this question. You're going to hate it, right? But you won't hate me, hopefully. All right, take a minute. Dust yourself off a little bit if you need to. Hydrate. I'll turn the light down on it. And decide for yourself what the answer here is. Right? Hopefully you narrowed it down to only 2 right away. Right? Should I do the whole thing? Call people out?
L4 or L5.
All right. So you guys are this is a pants question, right? How much time do you have? Like a minute. Less than a minute, right? A minute, maybe. Right? You gotta spread your time out if you need to. So right away you look at this question, you decide for yourself that it's asking you a specific nerve root, correct? Now you will assume a few things, especially if you look at the sheets that I gave you. Does everybody have the sheets, first of all? Okay. If you don't have it, you need it. You'll figure out why here in a second. Okay? So you look at it, and right away you decide for yourself which ones can we eliminate. 7, 8. C7 or C8? No way, no day. Right? Does C8 have a reflex?
No.
Boom. There you go. You're down to 3 answers. Right? So you've already eliminated C7, you told me. So now it's between C5 and C6. Now if you look at the sheets, and you guys know this from anatomy, because you guys are anatomy experts, right? A&P, right? Physiology as well. That there is some crossover at C5, C6. So the question is asking you, do you know the difference, and do you understand that crossover? Okay? That's what the question's asking you. So this is a third tier question, meaning it gives you the information and it makes you decide for yourself what the right answer is. Because there's only, just to be clear, there's only one right answer. Okay? You talk to a neurologist and you can argue to your blue in the face, they will leave you crawling out of that room because they will break you down and be like, well, let's talk about that real quick. Right? And then you find yourself in a deep, dark hole. What do you do when you find yourself in a deep, dark hole? Stop digging. Okay? If you find yourself in a situation where you're talking to a neurologist, right, or an orthopedist, and you are clearly out of your depth, you look at the person, you say, sir, I respect the knowledge, I will fix myself, and I will return with the correct answer. Right? But under no circumstances will you continue to engage. Because you, again, will be crawling, bleeding, bruised, and broken out of that room. Out of the OR. Woo! You get thrown out of the OR? Oh my goodness, I'll hear about it. Okay? Not to scare you much. Right? So what's the right answer?
B.
C6? Who thinks it's C5? You either don't want to raise your hand, or we are a very smart class. And I'll tell you something, and you guys shouldn't get a big head about this, right? I think you're a smart class. I really do. Okay? So you should know that. I think you guys are exceptional because you guys have adapted, right? Especially this early on, it's a junior semester. I see a level of adaptation that is uncommon. So you should relish that. But then again, nobody cares. Get back to work. Right? So the correct answer is C6. Okay? So let's go back and entertain why someone might answer C5. Okay? Look at your sheet. If you look under C6, it says brachioradialis reflex, correct? But in parentheses, it also says biceps, right? So it says biceps because, again, there's crossover there, okay, at the C5, C6 level, okay? But the important thing to understand is the dermatome it gives you is only C6, correct? Make sense? Okay? And again, we've accepted the fact that there's crossover between C5 and C6 for the biceps reflex, right? And what's the only thing affected by elbow flexion? Again, it's C6, correct? So then it says wrist extension. That is definitely C6. Okay? Is anybody going to correct me? Is there some involvement with C5 for elbow flexion? Does some biceps, correct? So let me tell you something. You need to understand that a reflex, correct, is testing the tendon, right? It's a stretch reflex. That's what it's called, correct? So if the biceps is out, that's why it can affect the tendon, correct? So it makes sense now, right? So if you look at your sheets and you decide for yourself, well, hopefully you decide for yourself that I'm right, right? Because I am. But you decide for yourself that you understand that concept of the stretch, then in the future, you'll think to yourself in certain injury patterns, this may be why they have an absent reflex. Do you think if somebody has a distal biceps rupture, they're going to have a biceps reflex? No, right? By definition, and we'll get into that. But they should still have sensation, correct? They should still have wrist extension, correct? So that is how you start to put these things together, okay? And that, remember I told you knowledge is power, and your knowledge of anatomy and physiology and orthopedics is essential for you to have that power, okay? Any questions about this? Is this an example of a question I might ask you on a test, like in the manner, right? Not this exact question, right? The answer is always yes. So this is an example, but I can vary this up a little bit, right? Not just me, pants. And I can take one part of the equation out and now ask you, to tell me what sensation should be present given these other two factors, right? Meaning the motor and the DTR. Okay, so there's a few different ways to kind of phrase this, right? So if you're sitting there and you decided for yourself you're just going to accept the fact it's C6, right? But you don't truly understand what I'm getting at, I encourage you to spend some time with this and look at it. Try to lay it all out and figure out what may be present when you're talking about cervical nerve roots and testing questions, okay? Do you guys want me to post that on the page? Or we got it? Okay? I didn't hear an answer, but the class leader will let me know. So when you look at this, I added this slide as a supplemental slide. I think it's relevant to talk about it now. Okay? And good job, by the way, deciding it was C6. That's good on you guys. Okay? But if you look here and you look at the nerve roots as they exit, C1 and C2 are not the same, correct? Where the nerves exit. Right? But then you decide for yourself, looking at this picture, and again, having your astute knowledge of anatomy and physiology, that when you get to C3, what exits below C3? C4. What exits below C4? C5, etc. Right? So it's important to understand that there is how many cervical vertebrae? 7. How many spinal nerves? 8. That's a concept you need to understand. Okay? Makes sense? Because that is not a given, right? It implores you to have an understanding of your anatomy and physiology when you're talking about levels, right? Because I already told you guys, when you're assessing a patient on trauma bay, right, if and when, you will have to decide for yourself what level you think the involvement is of the injury, or what levels based on your physical exam. So your ability to understand these sheets, these charts that I've given you, the information, right, is going to be paramount, because you got to do it on the spot. Make sense? Not right away. Right, don't get nervous. Any questions about this? No? Okay, and I'll go ahead and reference it. I also included this too. We'll talk about this today, obviously, kyphosis lordosis. We already kind of talked about lordosis, correct? Looking up at the lower, curving your back, right? So cervical and lumbar have lordosis, correct? And the thoracic and the sacral have kyphosis, okay? And we'll talk about cervical strains here in a second, so it's timely, okay? Any questions about anything here on these slides? Okay. You guys have lots of questions next Thursday. Joking, sort of. Only 50. I'll take them in the order they come. Okay, let's see if we can get this to work today. All right, so cervical strain, moving on. So cervical strain, so we talked about sprains and strains, correct? Cervical strains, you're gonna use the word sprain, you're gonna use the word strain, all right, because you don't really know, all right, sometimes. So, but this is a common self-limiting condition. Strain versus sprain, again, you'll have to decide whether it's the ligament or the muscle. A lot of things going on up in that area. But the protocols are similar, right? It doesn't matter, basically, is what it's getting at. You will treat cervical strains, sprains. Right? You can use that word interchangeably here because you can have involvement of ligaments and you can have involvement of muscle groups too. Whiplash is the most common, so we all know what a whiplash injury is, right? You guys see the advertisements with that lawyer, TJH, Thomas J. Harris or something like that. He's always talking about, were you injured in an accident? Well, this is what we're talking about, whiplash. Some kind of mechanism where the neck gets pushed forward, back, or back forward, and etc. Okay? It's commonly referred to as an acceleration-deceleration injury pattern, okay, with rapid flexion and extension. And again, MVAs are very common, motor vehicle accidents, okay? So that's demonstrating up there. Sometimes it's referred to as coup contra coup, but in this case it doesn't really fit. So I'll just say acceleration, deceleration with rapid flexion and extension, okay? Any questions about this picture? Top. The bottom picture there is supposed to show you how you can get into those hyperflexion, hyperextension, and how it can tear things, right? So it can be challenging to decide for yourself, is this just that paraspinal muscle groups, or is it more significant pathology, right? So are you going to get imaging? You are, that's going to help you, okay? But by definition, it's non-radicular, non-focal pain, meaning they just have pain here, right? Non-focal, not one particular area necessarily. If it's focal, right, say they have C-spine tenderness down the spinous processes, then you're more concerned about a fracture, correct? So that's what they mean by non-focal, okay? Anywhere from the base of the skull to the cervical-thoracic junction, okay? Getting back to our anatomy again. Sternocleidomastoid, that's SCM, right? And or trapezii, okay? The upper traps, right? That's what you got to work on when you're doing your pull-ups and all that stuff, okay? Getting swollen, okay? So patients will very commonly self-splint, meaning they will walk around like this, right, and just not want to move, right? So that's what they mean by self-splinting. They're not moving. They're self-regulating, if you will, okay? So mechanical pain, worst of motion. So you ask them to do their range of motion, right? When you're doing your physical exam, they won't want to do it because it hurts. And paraspinal spasms. Remember we talked about spasms a little bit yesterday? So if you see that increased muscle tone there, right, and you suspect spasms, can you walk up to Captain Carbiner? Did I get it right? And you say, and you start palpating, right, correctly with your sparkle fingers, or whatever Colonel Sylvester calls it, right? And you're pushing on the trapezius. I won't do it. There's a line. But you start palpating there, and you feel little spasms there, right? Those are called trigger points. Anybody ever heard that? Yeah. So you heard about trigger point injections? So she thought I was going to start doing a bunch of craziness. No manipulation, correct? I digress. But that's what we're talking about here, okay? Occipital headaches, can they get headaches related to that muscle tension? 100%. So if you treat the muscle tension, maybe you treat the headaches. You don't have to give them narcotics, right? I keep beating that bush, if you will, to get that info out. So increased irritability, fatigue, sleep disturbances, difficulty concentrating. That sounds like a typical IPAP student, right? So get a sense of baseline as well. Are you normally this irritable, or did somebody just ask you a question that set you off? right? Something like that, okay? Is that picture helpful? No, right? Because everybody presents a little bit different. But they may actually walk around like this, right? Thomas J. Henry, whatever his name is, right? I won't use his name anymore because I'm not advertising, but the patient may actually walk in like this, right? So they're doing that, where they're cluing you into the fact that they may have some muscle tension issues, right? They may not like to be in a well-lit room. They may have headaches, okay? So when you're doing your palpation portion of your exam, you're palpating those muscle groups, those areas, those landmarks, and this is the kind of stuff you'll see here, right? Paraspinal, trapezius, sternocleidomastoid, interspinous ligaments. How in the world are you going to decide it's an interspinous ligament? You get an MRI, it might not still not convince you of that, right? That's why I tell you cervical strain, cervical sprain. Those words are used interchangeably, okay? The big thing about this is it's non-focal, non-radicular. Not treated the same as if, though, it were radicular, correct? So they may have, again, decreased range of motion, but, again, this is where we differentiate it. This is a sprain or a strain, right? In this case, it's labeled strain, because there is no neurologic deficits on exam. We good? Okay. So plain films, for the most part, you're going to get those films that we talked about, right? Why? You're going to rule out fractures. If you have associated neurologic deficits, right, and you're not just convinced this is just a sprain or strain, again, you're going to get x-rays, right? Do a little digging. Elderly patients, we talked about fragility fractures, right? Remember those burst fractures we talked about, compression fractures, fragility type fractures? They're more prone to those, okay? Decreased bone mineral density, okay? So, again, when you get the views, you got to get to see all 7 vertebrae, so you got to see the top of T1, correct? To see wherever all those nerves exit, because C8 exits under C7, right? Good to go, all right? Not flexion extension films. What this means is there are certain conditions where you'll get flexion extension views, okay? But in this case, you're not suspecting those conditions, so you won't necessarily order a flexion extension view. Because does the patient want to flex and extend? So you just made a situation worse, right? Okay. Non-operative management is the mainstay for this. Okay. And what you have to do is you have to look at the patient a lot of times. You should always do this because you're going to document it. You're going to reassure them. You're going to tell them this is just a sprain or a strain. There's no fracture on X-ray. You have no neurologic deficits. This should improve with conservative care. You do not require high-level medication use, right? So what we're going to do is NSAIDs, RICE, activity modification, physical therapy, okay? That's an acute period in that first 1 to 2 weeks. Muscle relaxers, plus or minus. Make sure if you're putting a soldier or an airman on muscle relaxers, you know what they do. Because if they arm up, can they arm up and they're on muscle relaxers? No, that's an example, okay? Soft collar, that is an option, okay? Right? So especially if someone's splinting and you try to get them in a more neutral position and they feel relaxed in that position, okay? Because you don't want people necessarily walk around like this, right? You want motion, okay? I don't know if this is the first time I'm saying it, but I'll tell you this now. Motion is lotion, okay? So the more you get someone moving, the better off they're going to be. Right? And what's the enemy of orthopedics? Stiffness. So you don't want other problems. Okay? Doxepine or amitriptyline. Okay? If they're having trouble sleeping, right? But again, used cautiously. Right? No manipulation. How many times have we seen that now?
A lot.
A lot. Right? So manipulation is not good. Traction and manipulation are different. Right? I spent some time on that yesterday. And you want them, again, to return to activity as soon as possible because motion is lotion. You want to stave off any sequelae that you could otherwise avoid, okay? Any questions about that? That was meant to be quick because it's pretty straightforward. But again, how are you going to decide from a clinical vignette whether it's radicular pain versus non-radicular pain? Well, they're going to have radiculopathy, right? So that's your first clue. They're going to have, if they have radiculopathy, they may have neurologic deficits, right? So you're going to do a complete neurologic exam. Okay, and you're going to decide for yourself, based on your physical exam, your imaging, and your knowledge, that this is just a cervical strain. and treat it accordingly. Okay? Any questions about that? Pretty straightforward, right? Discitis, this is an area where I will tell you that we discuss it. If you happen to run into this in clinical practice, you will refer this. 100 times out of 100 times, right? 100%. Because discitis is not something you're going to play with, right? But there it tells you it's a bacterial infection, correct? So we already kind of know the workup. We've been through that a bunch of times, right? You're going to get all those inflammatory markers, etc. But we'll get to that. But by definition, it's the vertebral bodies and discs, right? So it's the anterior aspect of the cervical, of the spine, right? Most common in low thoracic and lumbar spine, okay? So kind of breaking it up here, it's not highlighted, you can't highlight the entire slide, right? But it's white when everything else is gold. So, but important to understand that discitis is, again, the terminology kind of gets thrown out there. Some people put a K in there instead of the C, so D-I-S-K-I-T-I-S, okay? But by definition, textbook definition, discitis is patients less than 5 years old, and vertebral osteomyelitis is patients that are greater than 5 years old, okay? So vertebral osteomyelitis, again, commonly affecting the thoracic spine, commonly, right? So that is something that you may see and you may suspect based on your palpation. We talked about finding landmarks, right? And deciding for yourself when you're at L1, and if you're above L1, you're in the thoracic spine, correct? So then you know you're in the lower thoracic spine, okay? What's the most common infecting organism? Pretty easy so far, right? Don't worry, when you guys get to infectious disease, you'll be like, I don't remember any of that. Because then you got a bunch of other bugs to remember, right? But pretty straightforward, right? Most common is Staph aureus, okay? So you see how it shows you there? That's the anterior aspect of the spine, okay? So that's the area in play here, right? It's in the word, discitis. There's inflammation of the disc and the anterior components, okay? So symptoms, very non-specific initially. They may actually just complain about just pain, right? Pain, pain, pain. My back hurts, okay? Fever and malaise can be common though, okay? So they may actually tell you that they have fever, or they may have a fever when they present, or they may tell you they have low-grade fevers that come and go, right? Is it important to ask the patient if they took Tylenol and when they took it? Yes, because it'll give you a sense of, you know, maybe I'm not getting the full clinical picture because they have some meds on board, okay? So back pain. So with kids, again, kids are difficult historians, right? Not because they want to be, but they just are, right? So they may actually report the pain to be more abdominal or thigh, which sounds weird, right? We know that those nerves run certain places, right? So if it's involving the spinal column, can it involve the nerves too? So maybe what we refer to as referred pain as well, okay? Kids, they very commonly will tell you that they don't want to walk, or refuse to walk, or they may walk with a limp, okay? Remember I told you when I hear, when someone calls me on the phone and says they refuse to walk, I don't know what to do, what do I hear? Challenge accepted, okay? Because my job is to go ahead and figure out where and what, right? Where is this manifesting, and to what extent is this really a refusal to walk versus they just don't want to do it because they have other things going on. You know, you take off the shirt, you see a big old superficial abscess there. There we go. We got our answer, right? So not everything is discitis, right? So you got to get to it. So low-grade fever again is common. Low grade meaning not 100.4 or higher, or 100.4-ish, or like 99.8. You know, it's difficult to like ascertain what exactly that means, correct? But when they walk, they lean forward and place their hands on thighs for support. I kind of mentioned this earlier. When you lean forward, do you take some of that pressure off? You do. Okay, so it's self-relieving, self-offloading. In other words, self-splinting like we described earlier. Okay? Tenderness to percussion on the spine's processes, I already mentioned that. Okay? You decide for yourself. You find the iliac crest, work your way across. What level should you be at? L4, work your way up. You find yourself in the lower thoracic, you're on the spinous process, there's tenderness. Booyah. Passive range of motion is painful, especially with flexion. So what that means is, yes, they're going to want to walk in a certain way, but when you make them do it, especially when you make them go way forward, right? Because when I'm talking about flexion, they don't walk where they're like basically hands to the ground, right? Just a slight flexion. But when you put them in more flexion, now they have pain. Because is it at that point then is it compressing the anterior components of the spine? It's pretty intuitive that it is, correct? So it's putting even more increased pressure. So don't get those two concepts confused, please. Okay. So when you get imaging, right? I already talked about this concept of end plates. Literally, the end plate is where I'm pointing here. This is the anterior end plate. This is the posterior end plate. On this side, guys, this is the anterior end plate. It's the ends of the vertebra, and this is the posterior end plate. Okay, that's what they're talking about there. You can see end plate narrowing, and what? Disc narrowing not apparent until 2 to 3 weeks after onset. Okay, so what you'll see is, does this involve the vertebrae? Yes. So the vertebrae are affected first, and then it invades, right? Because this is an infection, correct? It invades the discs themselves. Okay, then you see that disc narrowing, but it may not be apparent initially. Okay, bone scans can oftentimes be helpful because when you have infection, is there increased metabolic activity there? There is. If there's a question about it, right, you may get a bone scan. Okay, MRI though is a study of choice. Right? So again, MRI being something that you're looking for reactive changes in the bone and or disc issues. And you're looking again for those exiting nerve roots, et cetera, to try to explain some of those symptoms that the patient's having on physical exam. Okay? So it can help you confirm the diagnosis. Anytime you see the word confirm, especially in orthopedics, it's pretty much something we're going to do, right? You're going to get an MRI at some point. So, but it also defines the extent of the disease process, and you're looking for other things that can be complicated, okay? If you have an epidural abscess, like we talked about yesterday, if you have, or in the last couple of days, if you have space-occupying masses, is that going to cause compressive type symptoms? Yes, right? So you're going to want to know to what extent that is causing that. Can everybody kind of discern what's going on here? That doesn't look normal, correct? Correct. The answer is yes, right? Because if you look above it, and you look at how those discs look up here, and you look down here and you see how the disc looks there, right? And again, on this side, this looks normal-ish, right? And down here, that doesn't look normal, correct? Then that's going to clue you into the fact that you may have discitis, okay? White blood cell count may be normal in most cases. Again, this is a localized infection, okay? In most cases, it says, can it be elevated? Sure. But the white blood cell count necessarily won't tell you the full story, okay? But the ESR-CRP will be elevated. Are those specific and sensitive for any one condition? No, not helpful, but you're heading down the right path, right? So if you're going to get at it, especially if it's like an epidural abscess, you got to get at it, right? So this is, again, where you're going to refer, and someone may decide that it's clinically important or clinically relevant to do an aspiration, okay, to go in there and get some of it. Let's take a look at it, see what's going on. But it says what, 50 to 60% diagnostic. So is that 100% too? No, right? So if you're going to do an aspiration, it's going to be CT guided. This is not a blind thing, right? Don't go blind, okay? So this is not a spinal tap, okay? Considered if empiric treatment is not successful or another diagnosis is likely. So what does that mean? So even if you've decided for yourself, hey, this is this guidance, we're going to treat it, you give them empiric antibiotics, you cover for gram-negative, gram-positive, the most common bugs, the most common bug being Staph aureus. Could it be strep? Sure. Could it be other things? Sure. Right? When you do the empiric antibiotics, they're not responding. Okay? Now you gotta go after it. You gotta get a better sense of what's going on. What's the best way to get after it? Go after it. Right? Get in there. Right? So outcomes of disease, persistent disc space narrowing, and again, that could be, depending on when you catch this and how aggressively you treat it, some of that may be long-standing, right? You may not be able to reverse all of that, okay? But the hope is that you get to it fast and soon. Okay? Spontaneous vertebral fusion, body fusion. Your body is an amazing thing. It will do adaptive processes, right? And it may actually decide for itself, since it had infection there, right, and you treated it, that those vertebral bodies now have become one. Again, that's a form of trying to stabilize. Does that make sense? So you may actually have vertebral body fusion. So does that change the way articulation occurs at those levels that were affected? It is. So can they have persistent back pain even after treatment? Yes. Okay. All right. Sir.
So would you treat empirically before you got an image, like an MRI, say if the MRI is super delayed?
So his question was, would you treat empirically if the MRI is delayed? Is that what you said? If there's a delay in imaging? So it depends on your clinical suspicion, right? Remember I telling you guys, and I appreciate you guys, you come to me, you tell me either your story or you ask me a question about a certain condition, how I would treat it, right? The important thing to understand is you take all the components of everything I tell you guys, okay? And you put it together and you make a clinical decision, right? You make a diagnosis, right? In this case, you're not treating back pain, right? You're treating the patient for concern for either discitis, less than 5 years old, or vertebral osteomyelitis based on presentation, okay? So the way I document those things a lot of times is a history and exam consistent with vertebral osteomyelitis, concern for high-grade involvement of the spinal cord, spinal processes, the spinal column, that's what I'm trying to say, spinal column. Therefore, we initiate it and we will continue to monitor. Okay, that's more, does that sound like something you'd write in like a SOAP note in PCM level? You said yes? No, that's an inpatient note, right? So again, are these patients you're going to be treating these patients in your clinic?
Probably
No. How are you going to give these patients IV antibiotics? It says it right there. IV. So anytime you see IV in any slide deck for orthopedics, for example, or any surgical specialty, the patient's inpatient. Okay, I wasn't picking on you, man. Yeah. But you want to make sure that again, if you see this patient in the clinic and you have a concern for discitis or vertebral osteomyelitis, depending on their age, right? And that's nitpicking, right? But the terminology I'm saying, you will send this patient for further evaluation. What is that? An ER, right? All right, and then who's the ER going to call? Do you think they're going to treat it? Heck no. They're going to do a bunch of stuff. They're going to put the ultrasound on there. When you look at them weird, like, what are you doing with an ultrasound? Do we do ultrasounds with this? No, right? This is an MRI, right? But they love to do their little ultrasound stuff. They can charge for it, right? So, but this is going to be a higher level. A surgical specialty is going to be consulted, okay? Does that answer your question, sir? Yeah, I know it's a very vague answer, but it's still what you need to know because you will not stay and play with these. You will send them out. Okay, good to go. All right. So non-operative again, the usual stuff. In this case, it does say analgesics, right? It is part of the paradigm. Are we soulless monsters who don't care about pain? No, some of us aren't, right? But do you want to make sure you do what first? Do a complete neurologic assessment. Because if you give somebody the good stuff, are they going to be 100% with it? No, right? Especially if they're kids, they're going to be sleepy, right? Spinal orthosis, a brace, for 4 to 6 weeks for pain relief. That'll relieve that pressure at those vertebral levels, okay? So do you guys know what a spinal orthosis looks like? It's a big old brace. I'll find a picture and show you guys. But it's a big old brace that goes to the body, and it basically looks like a body brace, right? So it's the entire cervical thoracic region, right? Right? You guys with me? Okay. So is that sometimes custom fitted? Yes. Do we all have the same shape? Pear is a shape, by the way. Okay. But no, right? So, but initially they may be off the shelf. okay? But say they're doing long-standing treatment and they're actually discharged and they're still having residual pain, you might do a spinal orthosis. In that case, you'll try to be custom fitted, okay? I ran a spinal orthosis shop, so I'll find plenty of pictures for you guys, okay? Antibiotics, is it gonna be a day or two? No, 6 weeks, right? But that initial antibiotics is gonna be inpatient, okay? Because the last thing you wanna do is send somebody home before they're ready to go home, because you don't have those culture results back, et cetera, et cetera, et cetera, right? And you don't have a gauge as to whether they're actually improving, okay? And then when they get back home, you're gonna tell them to do a gradual return to activities. This is gonna be challenging because again, depending on the age population, some people wanna get moving faster than they should, okay? So, operative though, right? Rare, right? Unless again, it's long-standing or it's not caught early. That's why, like I was just mentioning, Lieutenant Bishop, you wanna make sure that you're aggressive about working these up, okay? Because surgical intervention should be rare. If you wanna go in there futzing around with the vertebral column of a 4-year-old, no, okay? But if you have an abscess, you gotta go after it. Are the antibiotics gonna be able to penetrate that abscess? Not necessarily, okay? So that's just a concept you guys will get used to when you get into next semester and you start talking about surgery stuff. Not orthopedic surgery, but other surgeries. Who would wanna work in those areas, I don't know. But referral decisions, red flags, it says it right there, all patients. You're never gonna play with these guys in clinic. You're just not, right? Which is bad news. Oral antibiotics, do they have any role here? No, it's IV antibiotics initially, okay? Especially if they have neurologic symptoms and they have indication that they could have an epidural abscess, okay? Lack of a response to empiric treatment suggests need for additional workup and or biopsy. What that's getting at is, say you successfully treat a patient, right? What's success? Well, the patient improves, okay? But then you still have ongoing concern. Why are they still having neurologic deficits? We don't understand. We don't get it. Could you do a more in-depth workup? Could you consult other specialties? Absolutely, 100%. Infectious disease was going to get a phone call from me. General surgery is going to get a phone call from me. I'm going to talk to my ortho spine colleagues, et cetera, et cetera, et cetera. It's not just going to be a one prompt. And I'm telling you what I'm going to do, right? So are you going to do that in clinic? No, you're just going to send it to someone like me, right? If I'm on call, call me. Talk to me, okay? Let me know what you got. I'll take it. Any questions about that? So this kind of seems like very kind of like nebulous, right? But what is discitis, right? What discitis is you have a high clinical suspicion based on the patient presentation. It's a 4-year-old child who has fevers, malaise, tenderness of palpation at the lower thoracic region, the inability to weight bear due to pain, right? And elevated inflammatory markers, plus or minus elevated blood cell count, and there's a pending MRI. That is what discitis is in the 4-year-old, okay? You're not going to send that patient home, therefore you will refer to a level of care that will be able to continue working that patient up and potentially admit that patient for further surveillance and further treatment. Ma'am?
So if a 4-year-old or a kid, they have the fusion of their vertebral body, will they still grow?
Okay, so her question is a good question. So, are there back questions? I haven't gotten any. I gotta pick on somebody at some point. But she said, so if they have discitis, right, and that you successfully treat them, is that what you're saying?
Well, like with the adverse outcomes of the disease, you know, when the vertebral body fuse, will they still grow? Like,
Good question. Okay, so what she's saying is, say you successfully treat them. I'm gonna go with that, right? And they get better, right? The fevers go away, the pain goes away, the patient gets back to a certain level of activity. But you see those changes on subsequent radiographic imaging, right, or subsequent MRIs, if that's the case, and you see evidence of that fusion of the vertebral bodies, right, of the desiccation. I won't use that term, you guys aren't familiar with that. So you see evidence of involvement of the discs, right, that is now seems to be not something that's going to resolve, okay? Will the patient continue to grow like normal? What do you guys think? For the most part, yes. Okay? But could they have chronic pain? Yeah, right? So if you have a patient, right, say now you're a PCM, you're seeing them, they're 10 years old now. okay? And the parents say, well, he had discitis, he or she had discitis at the age of 4, okay? I'm trying to maintain that posture of what age, right? 4 years old. So now they have chronic pain, they always point to their lower back, okay? Could it be related to the successfully treated, right? Discitis? Absolutely 100%. Okay? Hopefully what they don't have though is radicular symptoms, correct? Because then we have decided for ourselves after yesterday's lecture that sometimes drives us to do surgery, correct? But is pain the number one reason to do surgery in orthopedics? Who says yes? I'll find you. If you send a patient to me and tell that patient that has chronic lower back pain that I'm going to make them 100% better than anything I do. Okay? Because that's just not true. Okay? Did I answer your question at some point? Yeah. So hopefully so. Okay. So, but again, the neurologic deficits, if those persist, that we already got to that, right? That warrants further investigation, because maybe a sequelae. You guys know what I mean by sequelae, right? Something that came after, right? Something that was as a result of. You know, maybe it caused some kind of neurologic deterioration. Okay. I keep trying to not use certain words, but so now you need to treat them for that. Are you going to treat them for that as a PCM? Are you going to start a 4-year-old on a bunch of pain meds?
No.
Heck no, right? Am I going to do orthopedics? Heck no, right? So those are specialties. We all make choices, guys. Okay, specialties that have to deal with people that have these issues. Okay. Kyphosis. Let's burn through this. Kyphosis, really it's hyperkyphosis, right? Because we've already decided for ourselves. I gave you that slide. Well, there's normal kyphosis of the thoracic, right? And the what? Sacral, right? Sacral or vertebral, right? So this is really hyperkyphosis. So it's an accentuation of that normal kyphosis, okay? So numbers you need to know. I try to highlight numbers whenever possible to make sure you guys aren't memorizing a bunch of gibberish that you don't actually need to know. But what's normal kyphosis? Okay, so therefore, what's abnormal kyphosis? Greater than 50. Boom, there you go. You're welcome. So is it postural though? Do the people just have bad posture? Right? My 20-year-old son, he walks around like this. And I always tell him, you gotta head up, shoulders back, confidence. You gotta exude confidence, right? If nothing else. But it's also good for your back, right? So if they normally walk around stooped, right, and they complain about thoracic, right, so T-spine pain, and you get them to stand up, and the pain is relieved, right? That's what they mean by posture, okay? So it could be posture, okay? Make sense? It could also just be that you look at them and they walk around again with their shoulders slumped and their head not back, okay? But it's flexible and correctable. The concept in orthopedics, and you'll get more into this in block 4 too, is that in orthopedics, if it's flexible and correctable, a lot of times not as serious. It's kind of a general concept. Is that always the case? No. Don't hate me when you find something that isn't that. But for the most part, right? Girls, okay, sure, just a greater incidence, right? Does that mean that all girls have bad posture? No, right? So don't be that person who's, it's because you're a girl. No, that's not the case. It's just because that's just the incidence, okay? Sherman's disease, you need to know this, right? Sherman's disease is something you may see on pants. So the vertebrae, are wedge-shaped. Does that mean that they're wedge-shaped, that's due to discitis? No, not in this case. This is congenital, guys. They came out the chute, right, like this, okay? Sorry, it just slipped out. But more than 5 degrees in at least 3 consecutive vertebrae, by definition, that is something that maybe you'll see in a radiologist report, okay? Rigid, uncorrectable, okay? This is uncorrectable. Can you get them to correct their wedge-shaped 3 or more consecutive? No, okay? That's uncorrect because it's congenital, correct? The answer is yes. And in this case, again, you don't beat them down and say it's because you're a boy, but it's just what you see, right? You guys see this area here with the 3 wedge-shaped, okay? Over here with the 3 wedge-shaped, okay? You see the wedges? Would that lend itself more to anterior translation, otherwise known as kyphosis or hyperkyphosis? Yes. Okay, so there you go. So if you get an image, because you're always going to get images, right, on these kids? The answer is yes. So if you get an image and you see those 3 or more, wedge-shaped anterior wedge, then you're going to be like, I remember this from Ortho that one morning when I wasn't really paying attention and I was reading my farm slides, right? They mentioned something about that anterior wedging. This could be Sherman's disease, right? But is this something, when it comes to kyphosis, that a lot of times we have to do something about? A lot of times, and you'll get this concept, right, especially in clinical practice, that patients' parents will bring the patient in, dragging, kicking, and screaming sometimes, right, to your delight, right, with these concerns. And the concerns they have is cosmetic, right? Or it just doesn't look right. Is there something wrong, doc? Right? So that's something that you're very common to see, especially in pediatrics. Okay, and you guys will talk about tippy toers and all that stuff in block 4 too. Okay. Age, activity-related mid-back pain, right? But again, if it's correctable, should that pain be relieved? For the most part, right? It kind of goes with it. Makes sense? Especially if you get them into certain kinds of exercises that try to correct some of those postural issues. But should neurologic symptoms ever be present? No. And if they are, does that warrant further investigation? It does. And that's what that's getting at. Okay? So when you look at it from the side, right, you see this dude standing like this? Right, you see that kyphosis there? Right? And then when you get that child to stoop like that, it's like, wow, that's pretty pronounced, okay? So again, when you're looking at your patient, you want to stand at them from the side and decide for yourself what extent, just visually, do you ascertain that kyphosis is. What the Adam Ford bend test shows a sharp curve in Sherman's disease. You guys see that sharp curve there? You guys see that sharp curve? That's a pretty sharp curve, right? Everyone understands what I mean by sharp. Hyperacute curve. I don't know if there's any math guys out there, or women, right? But it's accentuated, okay? But if you lay the patient down and the spine flattens, right, then it's postural kyphosis, meaning you just changed their alignment, you just changed their posture, and you corrected it. Correct? The answer is yes. Okay. But again, neurologic exam is usually normal except for severe deformity. Okay. So that top picture, is that postural kyphosis? Yes. You don't see that sharp curve there with the Adam Ford bend test. Okay. Okay. So when you get radiographs, you're literally gonna get an X-ray that has a bunch of lines on it. The radiologist did, right? Like this. So what do you do with that, right? So those angles that they're measuring there are the Cobb measurements. Okay, they're trying to decide for themselves how to grade this or how to measure this out. Okay, so they're going to measure from T5 to T12. So is this going to be standing full body X-ray sometimes, or involve the T spine and the L spine as well? Yes. So there'll be certain views that you may have to order to get this. Okay. So, but again, what's the number? 50 degrees. Am I going to give you an X-ray and ask you to measure angles out?
Oh, shit.
Who said yes? Who wants 51 questions? No. Okay. We just understand that it's important to know these numbers, right? Because when you talk about surgical referral indications, that's what they're talking about. There is a picture of and I'll find some better ones too, because it's not necessarily the ones we use for discitis, okay? But there's a picture of that brace that I was kind of mentioning, okay? Do you think that one's custom fitted? Yes, okay? So for postural, the treatment, non-operative treatment, is postural exercises. For Sherman's kyphosis, they're skeletal immature, right? What does skeletal immature mean? They haven't finished growing? Well, yeah, so their growth plates are open, correct? So are you going to try to correct some of that kyphosis over time? Yes. So that's why you're saying you're going to do full-time wear a brace. Okay, but if you get to a point where it's greater than 50 degrees and they're having neurologic deficits, Right? Do you think if somebody has a great curvature of their spine like that, they could have some respiratory issues too? It's possible, right? So then you're going to talk about surgery, right? You're going to send patients to surgery. You're never going to promise the patient that I'm going to make them pain-free because I will find you, right? Especially because it's the parents. They're going to say, oh, my PCM said that you were supposed to make my patient pain-free. I will find you, right? But curvature is greater than 70 degrees, okay? So is this a big surgery? First spine case I did was a pediatric spine case. 8 hours, right? They pulled the typical prank, told me it was going to be a short case. I was like, I don't have to eat. I don't have to drink anything. We'll be in and out. 8 hours later, I'm like, holy Jesus, somebody relieve me, right? So, but these are long cases, guys. A lot of instrumentation, a lot of hardware, okay? Leave it at that. So when are you going to refer? Sherman's disease, refer them, guys, okay? Is this something you could stay and play with a little bit? Sure, but do the parents have concerns? Are you going to be able to answer all the concerns? Yeah. Am I going to be able to answer all the concerns? No. I'm going to punt too. So, but joking, sort of. Deformities of greater magnitude, especially if, again, like I said before, it's associated with components of structural abnormalities and or pain. Okay? Let's take a break. Yes, ma'am. I'm sorry. My allergies are kicking my butt.
Okay, anyway, so. I told him I'd tell you. Question for you. How would a patient with I don't know, I think society is self-correcting. Oh, yeah. 2-0? It's fine. Feels great. You don't remember from microbiology that only does like a 10% Oh, I'm sorry for trying to protect you. That's probably a better answer. Invest in a better mask. It's the thought. It's trying. Square bend. Yes. I should have worn my colors. I saw that shit. Sometimes when fishbowl on your head. Yeah. That's right. You want to it's not wrong. I could make something up. Oh yeah. It's always people with the Dakota noses. Yeah, I think you know how hard it was to get a mask. I love the people that I don't like it. Our kids are going to start wear masks. I don't like that. I eventually want to
The most basic.
First one in HIV.
No, so I it's like softball.
Sports, dude. Yeah, yeah. You know how I remember Lord I was just somebody that is going
That's what Mr. Rice said. Lordy, Lordy.
well, I think like Lord Oasis or whatever. I think something like yeah. Too much for one. Yeah, you do. Take it to chest, boy. What? I said. He's just charging the charges. Sorry, I should get one. It's not the other one. On the yeah, well, they're older now. Don't make fun of them. And I think, I don't know if it's the gas, but sometimes it's like they pick up slightly, so they connect to it.
All day.
And then, grab my jacket. Hey, come on.
All right, did everybody back for the most part? Everybody stay well hydrated, right? Change your socks, take your Motrin. All right, low back pain acute. This is something that you will deal with, all right? Everybody who's worked at a BAS, at a primary care clinic, what percentage of your patients on your patient roster, right, your patient schedule, are going to come in with mechanical lower back pain? 50%. The answer is yes, correct? Yeah. So you're going to deal with this. But low back pain, so I haven't even got to the slides, right? You guys are ahead. But I haven't got to the slides. Do you think these patients are going to have any neurologic symptoms? No, because then it's by definition, it's not just lower back pain, correct? That's why I hate the term lower back pain, because it doesn't tell the story. Please, 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 when you get out there and practice, guys, don't use knee pain as a diagnosis, right? If you do use that click box, knee pain, lower back pain, etc., in that subtext, right, you can click on the little box and write in there what you think is going on. I believe that due to history and physical exam and their chronology of symptoms, that this patient has non-radicular lower back pain, right? Or et cetera. Like, however you're going to put it out there, just to let people know, hey, this isn't bad. This isn't bad stuff, right? So I just implore you to use your brain a little bit more, okay? If you do a referral to orthopedic spine and you literally put lower back pain, they're going to usually say, what? Right? Because do they want to see lower back pain and spine? Do they want to see, let me qualify that. Do they want to see patients with radicular lower symptoms with lower back pain? That's the patients they want to treat. Because as PCMs, you should be adept at treating just acute lower back pain, right? Mechanical lower back pain, however you want to call it, okay? Lower back pain is a symptom rather than a diagnosis, getting to what I just said, correct? So 80% of patients with LBP, lower back pain, right? 80% have no specific diagnosis, okay? So again, you will decide for yourself how you want to practice, but just don't call everything lower back pain, right? Because that doesn't really tell the story, okay? So, history of repeated lifting, twisting, operating, vibrating equipment, right? So the guys aren't out there with the sledgehammers anymore, so I can't use that as an example. Don't worry, they'll be back. But say that they do operate heavy machinery, right? You guys know what CVs are? I don't have any Navy people in here. Yeah, Navy CVs, right? So I go get these guys to come in and they tell me about these equipment and machinery they're using. And I'm like, I don't know what that is, but it sounds really cool. Can I come down here and try it out? Right? Because, but you're like, does that machinery vibrate? So, oh, like crazy, doc. Right? So you're like, oh, okay. So that could be a causative agent, right? So you get them off that rig, get them off that machine for a week or two, let them heal, they do well. Okay? So again, history is important. Know what they do and know how they do it. Okay? All right? Probably a terrible example in a room full of non-Navy people, right? But you see what I'm getting at. So linked to poor fitness, job dissatisfaction, okay, right? Smoking, right? And psychosocial issues, okay? Here's the tissue for your issue, okay? Strains, paravertebral muscle injuries, well, that's pretty consistent, right? Muscles are strains, correct? Sprains, ligaments, could be the facet joints, annulus fibrosis, okay? But there's a donut, it's called the disc, What's the jelly inside? Is that the annulus fibrosus or the nucleus propulsus?
Nucleus propulsus.
Correct. So again, anatomy is knowledge. Knowledge is power. Power is awesome. Disc herniation, right? So they have that nucleus propulsus contents. They could have inflammation, right? So do you have medications that are called anti-inflammatories?
Yeah.
Yes. Okay. All right. Good. So acute onset following a lifting event. So you ask them, or your medic presents a patient to you that says, hey, they lifted a box. It weighed approximately 40 pounds. They twisted and turned, felt a sharp pain, woke up this morning. Now they have lower back pain and they're walking around like an old man. Sounds like me this morning, correct? The answer is yes. Okay? So leaning over to pick up a piece of paper. Not really sure what they're getting at there, but basically just the leaning. The pain can radiate, right? But is that the same thing as radiculopathy? The answer in this case is no. Okay? But it can radiate to the buttocks, the buttocks, right? Or the posterior thighs. When they stand up tall, right, it can accentuate their pain, and they can find it uncomfortable and need to change positions frequently, okay? Just to get in a better position that doesn't cause as much pain. That's all they're getting at there, okay? Physical exam, so your exam, you're gonna have tenderness over the back and then sacroiliac region. Again, we described lower buttock, posterior thighs. Range of motion reduced and painful, but they can still do it. It's just painful when they do it. Do you guys understand the difference? Because when you call me and tell me a patient can't do something, what do I hear? Challenge accepted, okay? But you'll find that they have pain with flexion. And is that just normal flexion, just a little bit, 5 to 10 degrees? No, they don't want to go into significant flexion. They don't want to bend forward, okay? So, but again, neurologic exam is normal. Imaging, you're going to get the usual radiographs, AP lateral obliques, okay? So, is this lower back pain? Yes, lumbar spine. So that's what you're going to get. So, what's atypical presentations though? This is where we start getting concerned about things, correct? So, if they have night pain, right? Or pain that doesn't go away with a certain amount of rest, you're concerned. If you have a history of significant trauma, right? How many times do patients, go out there, get injured, and don't present immediately? All the time. You don't get x-rays on certain patients, you will miss a fracture. I promise you. Even if it's a transverse process fracture that we really do nothing about, you'll miss it. So therefore, you won't treat it appropriately. Okay? I wouldn't say nothing. Don't quote me on that part. But I'm just saying transverse process fractures. What are you going to do? You going to do a big surgery for that? No. You're going to let it heal. Are you going to give them an orthotic brace? Yes. It's going to cause them to have some relief. It's going to relieve some of that tension there, some of that load. It's going to take some of that load bearing off, right? But again, you may defer, right? And this is based on clinical practice guidelines. You guys know about HEDIS measures yet? I don't remember what HEDIS stands for. It's an acronym. But basically, with lower back pain, we have this measure where it tells you don't necessarily need to get x-rays immediately for patients that don't have atypical pain, that don't have a history of significant trauma, and that don't have neurologic deficits. Because what's it more likely? Just a lower back sprain, whichever one you want to use, right? But as clinicians, if you decide for yourself based on your clinical acumen or your clinical suspicion that you need to get x-rays, you get them. Okay? I'm just telling you this is your out in case you're like, I'm too busy to get x-rays today, right? Does orthopedics ever see a patient for any musculoskeletal complaint and not get an x-ray? No, okay? But trauma will lead us to definitely get x-rays. And in fact, after we make sure the bad stuff isn't present, we may get even more additional views that we don't get into, okay? But it can be deferred for 4 to 6 weeks, okay? Normal age-appropriate arthritis, that's me, right? So if I walk into a clinic today and go see my buddy Nate at BAMC and I say, hey, Nate, I'm having back pain. He may look at me and say, yeah, me too, right? We're both older gentlemen, seasoned and distinguished, right? But I tell him I have a history of trauma. Do you think that if I just tell him the initial part of it, that he may say, we don't need to get x-rays. I know you got arthritis. You're old, right? But if I tell them the latter part of it, say I had a history of trauma, that should lead them in a different direction, correct? So again, if they're normal, age-appropriate presentation, and you believe it's just arthritis, can you defer? Yes. I don't want to teach you bad habits, but I will tell you that, again, you don't necessarily have to get them right away, but you must get them in certain conditions that I just outlined. Okay? Good to go? Okay. Because getting imaging on somebody who doesn't have those concerns, is it going to change your treatment? No. Right? In this case, the answer is no. Okay, not necessarily. Okay? But if they had a history of trauma and you find a fracture, will that change your treatment? Yes. Okay. All right. Enough on that. So non-operative, no significant trauma. You see these things here? Anybody watch Shark Tank?
Yep.
Yeah, I love Shark Tank, right? You see the latest and greatest. People come to you and say, hey, doc, I got this thing. I use it, it works. I said, that's great. Keep using it, right? And you say, hey, doc, this thing doesn't work. What do you recommend? I said, I recommend you watch Shark Tank for yourself and decide what you think will work, right? But you may see people that have these heating pads and these braces and coppers like the newest thing, right? I think Aaron Rodgers, Brett Favre, right? He's endorsing those copper products and things like that. These big old braces and stuff. So you can see all kinds of crazy stuff. But, are they going to have any neurologic deficits? The answer is no in this case, right? Phases, the acute phase, right? You're going to do symptomatic relief. Okay, so they come in, you decide for yourself, this is just acute lower back pain, lumbar strain, sprain, whichever terminology you think fits, okay, based on your exam. You feel paraspinal muscle trigger points, right? Then you may decide for yourself that's muscle, so that's a strain, okay? So, and then the second phase of that, see how there's 1 and 2? Then they return to full activity, because before that, you modify their activity. If you have somebody who's walking around like an old man, okay, or old women, I don't want to pick on men, but men are weak sometimes, right? So, but they're walking around like an old man, and they don't want to, and you tell them, hey, just don't do these certain things, but they're infantry, for example, do you need to give them a profile? Yep. Yes, but then the second phase becomes return to full active duty. Okay, do you want to do that as soon as possible? Yes. What is the enemy of orthopedics? Stiffness. Then you got a whole other set of issues. Okay? So again, you should make them appropriate. You remember how I mentioned that book I was going to give you guys? I'm not going to buy you the book. Okay? But I will give you a reference for a book. And will that have a handout for exercises? Yes. So, once they've done those exercises, you see them back in a week or two, you're like, oh, you're doing better. Keep doing them. I think you're ready to start some light jogging, and you kind of advance them back. You guys ever heard of the concept of walk to run? Yeah, there's a walk to run program, right? So I usually just shamelessly walk over to physical therapy, whichever duty station I go to, and steal it from them, okay? Because they haven't printed it out. Okay, when somebody finishes a course of physical therapy, they'll give them this sheet, right? And say, Captain Carbiner, I'm picking on her today. Captain Carbiner, I feel you are ready to return to full duty. This is how you're going to return back to running. Okay, will they see him again? Maybe not, because it's a program that's supposed to tell them, like, this is what you do. This is how you do it. Good to go? Incidentally, somebody asked me a question yesterday. What's the difference between the handouts that you give, right? So OC Shea, you give someone handouts, right? Is that physical therapy? No. In this case, the answer is no. I was waiting to see if you fell for that one. But good answer, sir. Good answer. He's too smart for that, right? That is called a home exercise program, right? Those are two different things. So if you refer to me and say that they've undergone a course of physical therapy, and I can look in the log, right? I can see if someone's been seen by physical therapy. It's not a secret, right? Unless it's off base, right? In which case I have to wait 3 years to see their notes transcribed into the system in a different tab. But anyways, the point being, if our guidelines say they must do physical therapy for 6 to 8 weeks, but you gave them a handout for 6 to 8 weeks, is that the same thing? No. So therefore, they have not completed the course of non-operative care. Good to go? Not to harp on referral guidelines. So HEP, home exercise program, that's what you give the patients. PT is what a physical therapist does. Good to go? Are they both rehab? Yes, technically yes. Okay. Then it's still physical therapy. Then physical therapy has given them a home exercise program. Why did you do that to me? Yes, I thought you liked me. So, but yes, that's a good differentiation. So So it's in yellow, right? I don't know, I don't see gold, but it's in bold gold, right? So this is something that PANCE harps on, okay? What is the number one way to prevent the recurrence of lower back pain? And it's to stay healthy, okay? Because it lowers the recurrence rate. So if you literally just tell a soldier, hey, I'm giving you this home exercise program, okay? When you get symptomatic relief from this, based on the shape of your body, and yes, again, hair is a shape, okay? I feel like you need to do these exercises forever, right? Then that is going to lower the recurrence rate, right? Because it's going to hopefully make them more fit and ready to fight, okay? Prevention education. So you want to, what are we talking about prevention education? I give you an example of somebody who lifted a 40-pound box, right, with improper body mechanics. What are you going to educate them on? How to properly lift a box and not do the same knucklehead thing, right? So that's prevention education. Good to go? Okay, conclusion, radiculopathy versus myelopathy. So we really talk about radiculopathy. We kind of talk about myelopathy. Myelopathy is a whole other thing, right? But you guys understand that when we're talking about Cauda-Equina syndrome, right, you're having significant compression. So you go from radiculopathy potentially, depending on the presentation. If it's trauma, all bets are off, right? You got involved in a huge car accident. But when you have myelopathy, could they have more significant neurologic deficits? It's the spinal cord. It's kind of important, right? So the answer is yes. So in Cauda-Equina syndrome, which you get to there, is that you're trying to get to it fast, you're trying to get to it aggressively, and you're trying to make sure that they don't progress from that perianal anesthesia, right? Numbness in that area, those moderate changes in those reflexes, and those intermittent paresthesias to now permanent what? Paralysis, permanent neurologic deficits, etc. Okay? So when you study that stuff, guys, study it that way. Okay? Cervical radiculopathy. So I think I beat that one to death. You guys did a really good job with that test question today. I will probably give you guys some more questions if you're okay with that. Okay? Is that cool with you? Okay. I'll push it out. Okay? Just to get the brain going. But you guys did a good job of that. You understand with cervical radiculopathy, excuse me. Understanding the motor, the sensation, and the reflexes and how they interplay is important. Okay? There's no way around it. You're going to get a question about that in some way, shape, or form, not only from me, but guess what a good pimping subject is in phase 2. Especially, God help you, when you go to neurology, right? They're going to want to, the first day one, they're going to look at you. They're going to say, Captain Daniels, let me see where you're at, right? Leaning back, looking all confident, right? He's like, I got this. Let's see where you're at, right? Go see the patient in room 4, right? They already know what the patient has, by the way, usually, right? But they look at the MRI. They know what they should suspect. And then come back to me and tell me what you think you got. And then you say, sir, you get this long-winded presentation. You say, sir, I think this patient has XYZ, C5 radiculopathy. Oh, C5? Tell me about that. Tell me about your findings on exam. Can you accurately describe it? If you can, high five, you're awesome, right? Don't worry, don't boast and gloat, right? Because they'll put you in a deep dark hole quick, right? With no shovel. But if you got it like that coming into the test, then you'll do well. Okay, when I say test, do I just mean my test? No, I mean PANCE, right? Okay, that's the big test, right? So enough about that. Cervical strain, by definition, no radicular symptoms, no neurologic deficits, right? Could they have some intermittent paresthesia? Yes, okay, I get it. You guys have seen lower back pain, some of you. So sometimes they feel like, oh, I got some numbness here. But again, is it something that's radicular, right? Can you do a physical exam outside of like making them bend and things like that, where they're having those radicular type symptoms? No. What percentage of people with cervical strain get better just from conservative care? I didn't give you a number, but it's high, okay? It's high, all right? Good to go? So discitis, understand the difference between discitis and vertebral osteomyelitis in terminology, because is the treatment different? Not necessarily. But when we get more into some other cases, right, you're gonna start realizing the vertebral osteomyelitis goes to other things. So now you're talking about adults, correct? Okay, so you gotta put this into categories. Okay? Kyphosis, we know that there's normal kyphosis, so really what we're talking about is hyperkyphosis. 50 seems to be a good number, right? You like 50? Okay, because 50 is a good number, right? And you know about those measurements that I'm gonna make you do on the test, okay? Kidding. So, but just understand you're gonna order this imaging, and when you get these results and you get these numbers, you know what to do with these patients. Do you know about Sherman's disease? Because if you don't, you will find out quickly that you may miss a question on PANS. Okay, because Sherman's disease is just, if you go by what PANS tests you on, these things exist everywhere. Every other patient has Sherman's disease, right? But that's just how they test, okay, really. I'm just being honest, okay? Even the test review tells you that. The guys that do the test reviews, they tell you, PANS will test you on stuff you'll never see, potentially. Okay, lower back pain, semicolon acute. Understand it again, like cervical strains, right? Now we're talking about lumbar strains and sprains, and that you will have no radicular symptoms by definition. Okay, by definition, right? And how do you treat that? Well, 80%, correct? That's the number. 80% will improve with just simply conservative care. Okay? Questions? With a question mark? Nothing? Okay. All right. So is this our last lecture block? It is. We still have a whole other lecture period tomorrow. Okay? So let's get into what we get into today. I don't want to burn through it though, okay? Because obviously we have a whole other lecture period. But I'm going to give you guys some time today. We're going to finish up essentially, right? And I'm going to give you guys some time to work on other things unless you tell me you want to burn through it. Okay, but I don't think you want to because we're about to talk about some spine stuff that you guys have been vigorously working on, furiously and vigorously working on as far as trying to discern like spondylolisthesis, etc. So let's not burn through this and just miss certain concepts, okay? So lumbar herniated disc. So we already talked about herniated disc. We've outlined the anatomical, right? The annulus bulbosus versus the nucleus propulsus, okay? So we understand that concept. So this is herniation at the lumbar level. Okay, how many lumbar vertebrae do we have? L1 through L5, correct? But let's just go ahead and shoot down to the bottom there, because we understand about radicular symptoms already, right? They're just going to be in different distributions. But if you shoot right down to the bottom there, what's the most common level? L4, 5, followed by?
5S1.
Is that, do you think that because it's more descending or more distal, that's because that bears the brunt of that weight bearing that we talk about? Absolutely 100%. So it goes to make sense, okay? So L4, 5, otherwise you should think of it as the L5 root, and then L5S1, you should think of it as the S1 root. What is your reflex for L5? Do you have a reflex for L5? Look at your sheet. No. Is there a reflex for L5? This is an exercise in just looking at your sheet, essentially. Okay? So is there a reflex at L5? If this is your first time you're looking at the sheet, you concern me. Okay? No. Anybody challenge me on that? What's your patellar reflex level? L4, correct? What's your reflex at S1? Ankle, Achilles. So the stretch reflex, right? What are you actually bumping on? The Achilles tendon? Okay. We good? Okay. We've established this now, correct? I could ask you a question this morning and made you think, right? But I just want to make sure we're on the same page before we move on. All right, good enough. Good enough for me. Okay. So when it comes to lumbar disc herniation, right? HMP, herniated nucleus propulsus, another way of saying it. Have you guys noticed that there's like 3,000 different ways to say certain things in orthopedics? Yes, or just in medicine in general, right? You have an example that Mr. Hansen brought up earlier. You have the intervertebral foramen, otherwise known as the neuroforamen, otherwise known as about 5 other things. Okay? But when you see HMP, that is a herniated disc. Okay? Severe pain with minor activity. Okay? So this is something that goes beyond just acute lower back pain, right? So again, history is important, okay? Pain exaggerated by basically living, right? You guys all sat today at one point? Wait, you're sitting right now. You walked in here, right? You went up and down stairs, correct? Right, unless you crawled, I guess. You didn't walk up them. You could have crawled, I don't know. But do you think that if you cough or sneeze and you have radicular symptoms, that could be more significant finding? 100%. So again, these are extremes, right? It's a spectrum, correct? So if someone's having radicular shooting pain just with coughing or sneezing, that could indicate more significant pathology, okay? Buttocks, and radicular pain, right? Again, your clinical suspicion will determine what level you think it's involved in, based on your physical examination and the patient's report. Is this picture helpful here?
Yeah.
Sort of, right? But what will the patient normally say? They will say things like, I have lower back pain that radiates down the back, down my leg. That's it. Then it's up to you to say, is it the anterior or the posterior? Okay? Does it stop above the knee or does it go below the knee? You see where I'm going with this? Right? Sciatica, does it go below the knee? Okay? Yes? Some people say yes. Okay? All right. So it can, right? The sciatic nerve is pretty big, right? So it has a lot of branches. Okay? So again, discerning which it is before you just call something sciatica, it may actually be a herniated nucleus propulsus, HNP, a lumbar herniation, however you want to call it, and therefore you decided for yourself it's not just sciatica. Okay, make sense? Don't use that word sciatica unless you know what it means. That's my point there. Trunk lifts to one side, so they have right-sided lower back pain, but they walk to the left. Does that make sense? Right? So they'll basically walk in a certain way to try to relieve tension or pressure. You remember that axial load I told you guys about? And we'll go through it in lab next week. When you have the patient, for cervical, right? You have them and you push down on their head, right? And you put an axial load there. Well, that's the same thing they're doing when they're trying to relieve that axial load, is that they're listing to one side. They're leaning to one side. Make sense? Because it relieves their pain. Okay, good to go? All right, straight leg raise. Now is probably the first time I'll start talking to you guys about physical exam stuff, but when it comes to physical exams, guys, I need to make sure you guys know that what a positive and a negative finding is for a physical exam. Is every special test that is out there, is pain a positive finding? No, right? It doesn't necessarily mean the test is positive, right? But in this case, is it? Yes, right? So we're leading with a test that is. Pain is the finding, okay? But in other tests, like when we start talking about shoulders, yeah? Some of you guys have talked to me about your shoulders already. You'll get my consultation fee, right? But instability, weakness, laxity, that's more of what we're interested in, not just pain. We'll get into that. But in this case, a straight leg raise is literally what it sounds like. The patient's either laying flat, supine on the table, or they're seated in a chair, and you have them raise their leg straight. Okay? Is their leg bent? No. Because it's called straight leg raise, right? So there's another test we do where we actually have their foot in a neutral position and then pull their toes towards their knee, right? So dorsiflex, right? And that one you could potentially start with the leg bent, with the knee bent, excuse me. So this is not that test, okay? Straight leg raise, pain on the symptomatic side, in the symptomatic side. I should probably say on, but on the symptomatic side, right? So if you do a straight leg raise, say somebody comes in, right, and they have right-sided lower back pain, and they're complaining about right-sided radicular symptoms, and you do a right leg straight leg raise, and they say that they have pain on the left side, does that make sense? That doesn't make sense, not to me at least, right? Because then I start thinking about spinal cord. I'm thinking about, well, if it's not to one side or the other, then it has to be central, correct? So that doesn't make sense to me. So you guys, I will try not to teach you too many bad habits, but some of them will come naturally. Okay, but there are criteria out there we use to see when people are faking. Right, called Waddell's criteria. I will allow you the opportunity on your own time to look those up because they're not part of my lectures. But that is an example of something that somebody may say, I have right-sided pain, and then you do a left-sided straight leg raise, and they report pain, on the right side. That doesn't make sense, right? Good to go? So what is the other one called? Crossed straight leg raise, okay? So when you do the cross straight leg raise, again, they have pain on the symptomatic side. So what's the difference between what I just said and somebody who's faking it, per se, right? Or Waddell's criteria, positive, I should say. Well, the cross straight leg raise should be literally something that goes with your physical exam, but also your presentation. Okay, so that's the difference there. Does everybody understand that? If you don't understand that concept, that's fine. We'll get into it next week, okay? Have you guys already done the straight leg raise in Clin Skills? Just for range of motion? Okay. All right, that's different. So another way you can do this test, right? So notice the difference between supine and seated. Is the positive finding the same? Positive finding the same, right? So another way you can do this test is those nerves, right? Remember that I just described to you, the patient's laying supine, like in this picture right here? And you take the ankle, right? It's normally kind of in a neutral or plantar position, and you pull back. Are you putting a stretch on that sciatic nerve potentially? Yes, you are, right? So it's another way you can do this test. So you can modify this test, is what I mean. Is that you do the straight leg raise, you get them into this position like it shows here, okay? Then you take that left hand in this case, and you dorsiflex at the ankle, and not only did they have that pain, but now dorsiflexing accentuates that pain. Is that a more positive finding? 100%. Okay. Do you guys recognize this?
Yes.
Yes. All right. All right. There's no secrets in my class. Okay. I gave it to you early though. Okay. So looking at this imaging now, you guys are experts at looking at axial cuts and deciding when there's intervertebral foramen encroachment or impingement. Correct? You guys saw it. I didn't even need to. I added that. The red circle with the blue fuzziness. I added that because people would look at this in my first iteration of this class and say, I don't see anything. I just see a bunch of white line. Okay, so the red circle is the pathology. Okay, so looking at this picture here, right? And looking at this picture here, okay, which side of the symptoms more than likely present? Left side. Is there also encroachment, though, into the spinal canal? Okay, so could they also have not only left side, but other symptoms as well?
Sure.
Yes, they can. Okay, so that's kind of the putting it all together of this. Okay, is that not only because you have central impingement, right? So you could have myelopathy, but you also have intervertebral foraminal impingement, so you could have radiculopathy. Does that make sense? Okay, so it's important to understand that depending on the amount or the location of the leakage, if you will, of that disc, you could have a clinical picture that's not clear. Okay, and then you get the imaging, you're like, oh, now it makes sense. Good to go? Okay. Symptoms longer than 4 weeks, what does that get to? Remember I told you guys can duck responsibility for 4 to 6 weeks and not getting the imaging. But now you get the imaging finally, right? And you see things on radiographs. So then you think to yourself, I'm always going to get imaging now, okay? All right? At some point. Maybe not in the young population, we know history of trauma, but neurodeficits on physical exam, sure. What kind of MRI do we get if we were looking at these, trying to confirm and further characterize these symptoms? MRIs with contrast, correct? Okay, good, don't miss that. So if they have metal or metallic foreign bodies or some other precluding thing, some factor, right? You guys talked about that in radiology, right? And if they have a pacemaker, can you get an MRI? Okay, so CT myelogram, good to go. Okay, look at the patient history, don't miss that. Differentiates between disc herniation and scar tissue. So when do we get contrast? If they have a history of surgery, okay? If they have a surgical history, I give you a vignette, I give you a clinical presentation that says this patient, it literally will say it in the text, right, or in pants. It'll tell you the patient had a history of previous lumbar surgery, okay? So something's different, right? Something's changed. How are you going to know what that different or that change is? How are you going to be able to further characterize that? Then you have to get contrast. Does that make sense? So there's a lot of if this, but not that, but when this, then that, right? So understand that. You guys like algorithms, right? So understand that algorithm. Good to go? Any questions about that? Does everybody see? I mean, obviously it's circled, right? But do you understand that concept I'm trying to bring about? Okay? Good. I hope so. So treatment, right? Are you gonna do this up top here? You guys got it like that in clinic? All right, no, that's a big setup. I will admit now, right? It's being recorded, so hopefully nobody will share this. I work spine. So we had that set up. I work for one of the big spine guys here in San Antonio, actually, one of the big practices. So we were able to do this here at that practice, okay? And what is that? That's an epidural steroid injection, okay? Is that machine called a fluoroscopy machine? It is. That's a high-level advanced way of deciding or determining when you stick that needle into that epidural space, that in fact you are in the epidural space and not somewhere else, right? Do you want to be in the spinal cord?
No.
No, right? Do you want to be anywhere else but the epidural space? No, right? So just short of that, right, because that's at the bottom, that's number 2, you're going to do all the stuff on top, okay? You're going to do, again, NSAIDs, RICE, stimulation modification, antispasmodics if you have spasms, right? Dead man profile, what is that? You guys are Army? I think Army Air Force share that. Are we still calling it dead man's profile? Ever heard that? So that's a thing in the Navy too. But dead man's profile it basically says can't do anything, right? So no heavy lifting, no running, no high impact activity. In fact, no lower impact activity either. This patient is supposed to do what they do, right, on their own, and that's it. No unit PT. The Navy sheet is like 2 pages long, right? Because the Navy's like treats you like a child, right? But the Army one in MedPros basically says again, no CFT, no nothing, right? PT at own pace. That's the guideline, okay? That's a dead man's profile, okay? So most will improve in 3 to 4 weeks, hopefully, right? If they have non-progressive, non-advanced disease, right? But if you get to number 2, and again, we're talking about epidural steroid injections, then that's a referral, correct? Some ortho spine guys will do these in clinic. Like I said, practice I worked at here on the civilian side, we did them, but not necessarily in the military. Sometimes you have to send them to pain management, and they'll do the injections. Good to go? Pain management, is that sometimes anesthesia? Yeah, there's anesthesia providers there, right? They work in and around the epidural space, right? Anybody who's had a baby or knows about somebody who's had a baby knows that they do things in and around the epidural space. So how many are you going to do in a 6-month period? No greater than 3, right? That is a rule, okay, for you. If they get to pain management though, and they're doing them, they usually give them what they call a break or a vacation, right? Or just a period where they don't get injections. But sometimes these patients get injections for years, on and off. Yes. But as a rule for you guys, no greater than 3 in a 6-month period, okay? So pain management and interventional radiology, those are your go-tos, okay? Any questions about that? So you have somebody with a herniated disc, but their exam tells you that they have, do you have a question? Yeah. Okay, good question. So for ESIs, right, epidural steroid injections, abbreviated ESI, okay? So her question was, how long should the patient get pain relief? Okay, the answer is variable, okay? Some patients will get 100%, because there's a difference between the amount of relief and the duration of relief. You guys understand that concept? Okay. So some people may get 80% relief of their pain for 2 weeks. Then they get another injection, they get another 10% of relief, and that now lasts for 3 weeks. Then they get a third injection, they get 100% relief of their pain, but that only lasts 1 week. That math doesn't seem to make sense, does it? It doesn't, because nothing adds up. So it's variable, is what I'm saying, okay? But it's important for you guys, like if you're doing a steroid injection, for example, get a good stretch there, sir. Yeah, if you're doing a steroid injection, for example, you're going to ask your patient, like, how much relief did you get, and how long did it last, right? You see them for a follow-up, okay? So these are concepts I want you guys to understand. That's a really good question. I can't answer that question, obviously, right, because it's variable, right? So, but I will tell you this, once a patient gets 0% relief of their pain from ESIs, do they keep doing them? No, right? My hope is no. Now if they're getting 20% relief, and they never get above that 20% relief even with 3 injections, will they continue doing them? Maybe, but is it indicated? Probably not, right? Has the patient usually at that point reached a point in their disease process where they need a referral to a spine guy, right? Whether it be ortho, spine, and neurosurgery, at least for a consult? Yes, but is that ESI, is that a checkbox for a referral sometimes? Yes, the patient has done non-operative care to include ESI, okay. He's reporting no relief from the injections that normally provided 30%, 40%, 100% for however long. Therefore, I feel that a surgical consult is indicated, and I have gone ahead and ordered a MRI with contrast because the patient has a previous history of surgery, spinal surgery. Make sense? You have done all the correct things, guys. High five, 100%. Okay? Good to go. Operative, again, non-operative treatment failure, decrease the quality of life. What is QOL? Quality of life. Work, play, sleep. That is quality of life. That's how I was taught it as a junior resident. I'll never forget it, because God dang it if it's not true. Right? Most people will go away until those 3 things are affected. In the military, it is work and play, they're kind of the same thing. It can be, right? If your play is to go out there and jump out of helicopters, then you'll come and see me, right? And you'll decide when it's time to get a surgical consult, right? After you've done all that non-operative care, okay? Discectomy plus or minus fusion, not to get too much into surgery stuff, I hacked this slide big time, okay? You guys don't need to know about spinal surgeries in depth, okay? But discectomy, let's talk it out. Discectomy, you take the components of the disc out, right? Hopefully not the whole thing, correct? Because then you got to put something in its place, right? You got to put a hockey puck in there. Just kidding. But you got to put something in its place, correct? Isn't that what that is right there? Okay? So something in its place, if you take out a certain percentage, because now you've destabilized that vertebral column, correct? So discectomies sometimes are micro discectomies. Meaning they just took a little piece out. Okay, and sometimes the spine guys will do those under microscope. They literally have this big microscope over the patient who's laying on their stomach, right? It's fun times to put something on their stomach. Do they go to sleep in their stomach? No, you gotta flip them, right? So that you know, if you ever see it, you'll be like, man, it doesn't lie. This seems barbaric, right? But there's special tables for this too. They put the patient in a position in an easier way. So, anyways, the point being, if you take out a lot of components of the vertebral column to include the discs, you've destabilized the column, therefore you have to do a fusion. You have to fuse those 2 vertebrae together to stabilize them. That's it. That's all I want you to know. Do you think these bars and these screws here, that's a big surgery, right? So that's not going to be something that like a general orthopedist will do. So send them to a ortho spine or send them to a neurosurgeon. Good to go? Okay. Lumbar stenosis, we'll talk about this real quick. Narrowing of 1 or more levels of the lumbar spinal canal, that's the space for the spinal cord. Okay, so remember we talked about, now we're finally getting to it, right? We're finally getting to that spinal cord, the spinal canal, correct? So stenosis denotes that there is narrowing or compression, right? And then when you have compression or impingement, Then you get to myelopathy, correct? By definition. Do we agree? Okay, so stenosis does not necessarily mean that they have myelopathy, but once the stenosis gets bad enough, they'll have myelopathy. Are we there? Okay. So subsequent compression of nerve roots. So if it's pervasive enough, remember that picture we showed earlier, and this picture shows you here. It's not only encroaching on the spinal canal, right, in this picture here, but now it's made its way over to that intervertebral foramen as well, so you can have radiculopathy as well, okay? 30% of those older than 6 years old, I am not quite there, so don't look at me, okay? But that's to say that a third of your patients, right? So if you guys are working at the VA, okay, some of you guys will find that the VA is lucrative, right? So you'll find yourself at the VA, okay? Take care of those, the patients you're charged to take care of. They've been through a lot, right? Some of them have been through a whole hell of a lot. So, but again, you can assume that a third of those patients may have some degree of lumbar stenosis. What level is that common at? L4 or 5. Does that kind of go with what we talked about earlier? Okay. All right. Notice how I didn't put L5 one there. I took that out because then you're gonna start talking about other subsets and whatever. Most common levels L4 or 5. Okay. Neurogenic claudication. You remember that shopping cart sign I mentioned earlier? Okay. If there's stenosis and narrowing in the spinal canal, by leaning forward as if though they're pushing a shopping cart, right, at Costco, right? I gotta go to Costco this weekend. But it may relieve the radicular symptoms. That's not to say that they don't have radicular symptoms, but it's relieved by leaning forward, okay? One or both legs may be affected, okay? Symptoms may improve, again, with that forward flexion. That's in bold gold. That is your shopping cart sign, okay? And extension will actually narrow the spinal canal. And that lends itself to what we're talking about with that compression, okay? Questions about that? Okay, this is where I first introduced this topic, right? I don't really like the fact that vascular claudication is thrown into my lectures, but it's important to understand that there's a difference between neurogenic and vascular claudication, okay? I want you to memorize this chart. I'm going to ask you 35 questions about this chart on your upcoming test, okay? All right, but the important thing to understand is someone at some point will ask you about vascular claudication, okay? So neurogenic claudication, it's nerve related. Neurogenic, break it down, okay? Is the patient going to have neurologic symptoms? Yes, okay, so that is the mainstay of this, okay? So when somebody, look at this here, palliative factors, right? Palliative factors, what does that mean? It gets better, right? So palliative factor for neurogenic is sitting or bending forward. Is that the shopping cart sign? Okay, we're good. All right, walking uphill, painless. I don't really know where they come up with this, but it says painful for vascular, okay? For the bike test, when someone's sitting on the bike, will they naturally kind of lean forward to? Should it affect their vasculature? It can in vascular claudication, but should it affect their nerve pain? As long as the position they're sitting on that bike on is not the position that they're having the most symptoms in, the answer is no. You see where I'm going with this? And then everything else is physical exam findings, like wounds that won't heal. Does that sound vascular? Like areas where hair won't grow. Does that sound vascular? Okay? So should that be neurogenic? No. So that's how you should kind of think about these things, okay? Right? So you guys, where it says pain character, when the patient describes the pain, right, it should be neurogenic, right? It's neurogenic claudication, right? It should not be something that leads you to say, well, it's cramping. Does cramping sound like a word I've used at all at any point in my discussion about anything spinal? No. So that sounds like, again, do the muscles get blood? Hopefully. In vascular claudication, do they stop getting blood? Yes. So that's vascular, guys. Okay? Again, memorize this chart, 35 questions. Okay? Just kidding. So adverse outcomes, all right, so this can progress, obviously. As you get older, bones get brittle, compression progresses. So again, you evaluate your patient along a timeline, right? Is it appropriate to get repeat imaging if their x-rays are older than a year old? Some say 2 years old. Yes, the answer is yes, especially if you're gonna try to refer because maybe you missed something. Okay, before your referral, and you realize, oh, I should this into someone else. Okay. Physical exam, leg weakness is uncommon. Okay, all right. So in this case, right, when we talk about nerve root, we're talking about radiculopathy, correct? As it exits the intervertebral fluid. So this is lumbar stenosis. This is stenosis of the lumbar canal. If it progresses to intervertebral foramen encroachment or impingement, then you'll have leg weakness. But just lumbar stenosis itself, right, because that's the title of this slide, correct? Just itself does not denote that the patient will have leg weakness, okay? But they may have decreased reflexes, okay? They could have sensory changes. Proprioception could be impaired, okay? What's a good test for that? Romberg, right? That's patient proprioception. What is proprioception? So that's the patient's ability to decide where they are in space and time. I keep saying time, right? But just space, right? Time is for the crazy people. But so spinal imaging, you can see all this stuff, right? All that osteoporosis, osteopenia may be present, right? So osteopenia, not the same as osteoporosis. You can see osteoarthritis, correct? All right? So does this look like my back x-rays? Maybe. I'll never tell, okay? So non-operative, again, patients that are older, kind of nail it down, they don't have significant radicular symptoms because this is just stenosis, right? NSAIDs, rice, activity modification, physical therapy, water exercise therapy. Anything you can do with the water, is that low impact? So that's when you talk about low impact exercises, hydrotherapy is good, okay? And then ESIs, that plays a part here too, right? Okay? How many are you going to do in a 6-month period? 3. Not you do, but someone else will do it, right? It's your job to monitor these patients. Just because you refer somebody to pain management doesn't mean you're done. They're still your patients, right? So when do they get to surgery? Again, decreased quality of life, right? Workplace sleep. Big, does that look like a big surgery? Yeah. But that's like a 3-4 hour surgery right there, at least, right? You want somebody who takes their time, by the way. Speed is not a measure of success and excellence, okay? Decompression and or fusion, we talked about this, okay? All right, so when are you going to refer? Now you don't just have stenosis, you have neurologic, you have gait disturbances, and you have bowel bladder dysfunction. That bowel bladder dysfunction, should that concern you? 100%. You need to work that up, okay? That's it. Have a good day.